And I am with Connection. We are in booth 12 today and look forward to seeing you there. We're a national technology solution provider focused on delivering the best in products and services for the past 40 years. Welcome to our next session today, titled Innovation in Hospital at Home, presented by Dr. Caroline Yang. Dr. Yang is an attending hospitalist physician at Brigham and Women's Hospital, interested in the intersection of clinical care, policy, and innovation within healthcare. She is faculty at Harvard Medical School and attends on the inpatient service. She also cares for patients in Brigham's home hospital program, which allows patients to be cared for in the home utilizing platform-based technologies that integrate remote monitoring, team communication, and virtual visits and telehealth. Please join me in welcoming Dr. Yang.
Hi, good morning, everyone. Can you guys hear me okay? I have my own, perfect. So I'm really excited that you guys are here with me this morning for the first session of the day. Well, I guess you guys had a lovely keynote this morning. But this is a really exciting time where in the last decade or so, I would argue that there's been so much change and evolution of the way we deliver healthcare. And one of those ways that has been, I guess, more popular and common in the last 2 years or so has been this model of caring for patients at home who are at an acute level. And so I'd love to talk a little bit more about the home hospital program, specifically at the Brigham, but also the model in general. So some things I just want to make sure we cover today is explaining, first off, what home hospital is, what digital tools that we're using in the home, and then around the technology, what challenges and opportunities we see, and then how digital health innovation could enhance acute care in the home, and then what we see moving forward with this model of care. So, a little history. Home hospital, actually the first concept really came about in 1994 at Hopkins. So has been around for almost 3 decades, but really, like I said earlier, became more popularized in the last 2 years during the pandemic. And I'll get to a little bit more about the factors that made this so, but what it is as a model is it is acute care, so it's inpatient level of care that you have traditionally seen delivered in the hospital when you're quote unquote admitted to the hospital, but it is provided in the home. So a lot of the services, the doctors, the nursing, even pharmacy, lab, those services are delivered to the patient in the home. And there's other ancillary supportive services that include like meal delivery, home health aides, social work, physical therapy that augment that full inpatient experience. So like we like to say, it's where we bring the hospital home to you. So a question that we always get asked is, can anybody go? Does everybody qualify for home hospital who would normally be admitted into the hospital setting? And the short answer is no. The longer answer is we hope so in the future, that we can expand the types of diagnoses and the types of patients that we take. But we really decide who qualifies for our home hospital program, specifically at the Brigham, based on several factors, including where the patient lives, what diagnosis they have, what they're admitted for, what types of comorbidities that they have, how frequent are the visits that they'll need from nursing, from a physician, and that also loops in how frequent IV medications are delivered, and therefore, how frequently are they requiring that in-person touch. And then home situation and supports. So, folks who don't have the privilege of having a home, who are homeless, or maybe are living in shelters, or even a rehab. There's a lot of other complicating factors that make home health care difficult for those folks. So not everybody is a great candidate for home hospital, but just like any other telemedicine solution, televisits in the ambulatory setting are not a good fit for everybody. So I think it's important to keep that in mind, but it really does help provide an alternative option for folks who are good candidates. So the model that we have at the Brigham, this is sort of a pictorial of the patient in the center, and then a lot of the services that we provide. So we have 2 daily nursing visits. So we have a nurse go out in the morning and in the afternoon to deliver medications, take vitals, do an exam. So the typical touch that a physician or a nurse would give happens twice a day, and the physician once a day with the nursing, or on their own, virtually or in person. The nursing visits are always in person, and the physician visits can be virtual or in person. So there is that degree of flexibility. There's always monitoring happening for the patient in terms of biometric data. So we do have different RPM or remote patient monitoring devices that we use to keep track of our patients and watch their pulse and their temperature and other vital signs while we're not physically there in the home. So we do deploy a lot of technology in the home and utilize a lot of digital solutions in the home in order to be present when we're not present. We have access to the patient, and the patient has access to us 24/7 via traditional modes of communication like landline, cell phone, but we also have different digital solutions that we use where we can allow for video and for text and for call via certain platforms that we utilize. So it gives us many options to reach our patient, again, when we're not physically there with them. We also do lab testing, like I said, in the hospital. We also can deliver that lab testing at home with our nursing staff. We have paramedic staffing. And then we have, so we have lab testing, but we also can check vital signs and other vital markers in the home. So this is just a model of our team communication. So this is physician-centric, just an example of how important it is to stay in communication with all of the players and the stakeholders, including the patient, when we're delivering care at home. And so we are talking to case management, to social work, to pharmacy, to the lab, imaging. We're able to provide all of those services in the home. And as the physician caring for my patient, I'm constantly quarterbacking these lines of communication with all of these different players. We have specialty services that we still contact, so the cardiologist, the GI, because everything is within network or within the Brigham, in general, we're able to use those consulting services that I would typically consult in the hospital when I'm servicing the inpatient service. We have an interesting role with program associates who do a lot of the logistical support for us, patient screening, patient consent, equipment, that you don't typically see in an inpatient hospital model. And then, again, nursing EMT, they're really the hands-on, on-the-grounds service that we have for our patients in the home. So the way that the patients communicate with providers, including nurses and physicians, or our EMTs, is in person when we do our daily visits, or virtual, where the patient has access to a patient application, a patient-facing application on a tablet that we provide them, and can connect with us via text, phone, or video. And then our nurses, when they're out on the field with the patient, they have access to what we use, Microsoft Teams, to do video or call, or we can do a phone call, just a landline to mobile, which we have an MD phone, or mobile to mobile. So the very traditional call functionality. So there's multiple options for patients to communicate with us. Whereas if you think about in a traditional inpatient room, or when you're admitted to the hospital, really they can buzz you on the buzzer, and that's how they communicate with you, or they shout. There's very limited ways for someone to reach a provider, and this way almost gives us new ways to communicate with our patients all the time, anytime. So just some example technology platforms. Again, these are specific to what we use at the Brigham, but we have at the top is just an example of what we use, which is a patient-facing application on a tablet that we provide to every patient that is admitted to the hospital, to home hospital. And it allows them to, like I said, communicate with the provider, so video, text, call. But it also has other interesting services that sort of have daily reminders or tasks built in that they can add so they can engage with the technology, and the physicians can also place these reminders that will then remind the patient, or the nurses can. And then they can see their own biometrics and their own data. And then, like I said, they can communicate with providers asynchronously or in real time. There's the clinician-facing application of the same application on both a web and a mobile device. And that allows the physician or the nursing provider or the EMT to see live biometric data. So we can see at any given time what that patient's pulse is, their temperature. There's fall detection on some of our devices. We have scales that are Bluetooth, so we can kind of see the weight trends. Those types of things are all visible on the application. We do task management, so what needs to be done for each patient, and that can be seen and adjusted by the staff who are on the team. There's clinical information on the patient handoff, as you might see within different electronic medical records, and then there's inventory management, so which is, again, very unique in a home hospital model where we have equipment that we need to track, and we need to make sure we know where some device is at a given time and if it's working, so we're able to visually see, what's the battery status? Is it connected? Probably one of our biggest challenges is that connectivity and making sure we're getting data all the time that we are wanting it. Other technology that we use regularly is our team communication. As I alluded to earlier, we use Microsoft Teams. So we are constantly on chats about what does this patient need, are you ready for a video visit? Those types of things all happen on Teams in general. Again, this is for the model at the Brigham currently, and every other home hospital program, I'm sure, does something a little bit different or maybe uses a different technology solution. And then our documentation, our coding, our billing, our orders, lab results, all of that still sits within, at the Brigham, Epic, but the electronic medical record. So if you can see, as great as it is to have a few services or a few technology solutions, we still have to use multiple solutions. And there is inherently some redundancy that occurs. So there might be vital signs in the patient application or in the software solution we use, but it might also be, inevitably in the electronic medical record. And some of it's automated, some of it currently is manual, but the ideal is to have less, because then there's less room for redundancy, error, or missing information. So we use remote monitoring devices to watch our patients' vital signs, and whereas you might have nursing do it sort of periodically, but more frequently in the hospital, we do it on a continuous basis for most. But there are obviously, like the weight, when you take a weight, it then will input, if it's connected by Bluetooth, the oximeter, when the patient is putting on the oximeter. We have a fall detection bracelet. We can do blood pressure. We have blood pressure cuffs that are Bluetoothed as well. So everything is connected. We have one thing that is 24/7, which is this vitals monitoring patch. And it has a single lead ECG, can tell us the temperature, the pulse, the respiratory rate at any given time. So, technology. There's definitely benefits, but also there are big challenges to using technology, specifically in the home and to the degree that we want it in an acute setting. And so some of the biggest challenges, as I said earlier, is connectivity is definitely number one. So not everyone's connection, signal, Wi-Fi in their home is good. In the hospital, we can control that. We have good security, because usually, as you know, hospital medicine has sat within the four walls of the hospital, and there's a lot more control of sort of the cybersecurity aspect of patient data. And so when we take it to the home, we're creating a new environment that introduces possible risk. And so that sort of speaks to connectivity is a challenge, security is obviously by proxy, the integrity of the data is super, super important to maintain. And so making sure that the data that's coming in is something that we can trust and make good clinical decisions based off of. And then there's just so much data. So what's important? What data do I want to listen to? And how do I know that the data I'm getting is trustworthy? So that's also a huge challenge. As we have more data from remote monitoring devices, I think it's really important to be able to decide what I want to listen to and what's relevant to me and what types of information I'm going to make my decisions based on. And then the data is on multiple platforms. So, maybe we have some patient information we've put on Teams in our chat conversation, but there's also some objective data that is sitting within the patient applications we use or the biometric monitors we're using. So being able to reconcile all the sources of data is a big challenge. Again, data is everywhere. It's in the patient's chart in Epic. It's within our conversations, our different chat route, our messaging threads within Teams. It's in our biometric monitors, even patient messages to us through the application. Sometimes patients will even text my MD phone. So keeping track of, oh, gee, where was that blood pressure from this morning? Or, oh no, who said, where did they live? All of that data is sitting in different places, and being able to remember where it is and if the data in one place is the same as the data in another place is definitely a big challenge. And the data is structured differently. So on the back end, the data does not, quote unquote, look the same. And so being able to streamline everything is super critical. And then not all platforms currently are interoperable. Some are, and there's a big push towards it. And I think that's the right direction of and how things are moving. But still a challenge in the current day of how we're operating. So I think this is all to say it's super important as a clinician and as a physician delivering the care that my decisions are only as good as the data I'm using to make those decisions. So it's not to say that the traditional model of manual transcription where the nurse goes to the bedside and takes a vital sign and then transcribes it manually into the chart doesn't have error or is not error prone, but the same concept. When I see a blood pressure that I'm seeing in the chart that was manually transcribed, I'm trusting that and I'm making clinical decisions based on that data. So whether that data is reliable or the data coming from my biometric monitor is reliable is all super important because it influences what kind of decisions I'm making for my patient. And so as we get more technology and more digital solutions, this is more and more imperative because there's just going to be so much data, and being able to decipher what's important and how to sift through all that data is going to be a big challenge. And then, in terms of additional challenges, the actual technology we deploy in the home, one is just how many options there are. There's a lot of competition in the RPM space or the remote monitoring space. So vendor selection is really, really important, making sure things are FDA cleared, HIPAA compliance, those types of things. And then something that you don't necessarily think about, but especially when you're developing digital solutions, is the reliance on the end user. So while the physician or the nurse can help set it up, we do rely on the patient and the family and caregivers, anybody who's involved in the patient's care, to be able to engage with the technology, turn it on, make sure it's connected to the Wi-Fi, follow instructions, use the video function, call, text, those types of things. It has to be the right end user in terms of the patient side to make sure that that is being optimized, the technology is being optimized. It's not the best for every patient, as telehealth is not the best for every patient. So we have hearing impaired patients, sight impaired patients, dementia patients. So to expect them to interface with different technologies is maybe not as feasible. And then again, it does not replace hands-on evaluation or intervention. So if a patient has an adverse event or an escalation, those types of things that require hands-on, technology as it currently stands does not replace, the human touch. So that's still really imperative. And then the way I like to think of it is from challenges, though, come opportunities. So as technology becomes faster, which it inevitably will, more precise, more secure, more affordable, this will open a lot of doors to opportunities to reduce redundancies, to seamlessly integrate data, to increase efficiency, so to decrease the cost and time to diagnosis, to treatment, and then to optimize the processing and the presentation of data to improve the care delivered. So with so much data, it is really important to have technology solutions that will be able to, again, select for the most important, the most relevant data, and present that in a meaningful, comprehensible way to the end user so that those decisions, those clinical decisions, can be made. And then to automate processes. Not everything in medicine can be automated, but I believe that there are a lot of things that we do that spend a lot of our time that could be automated safely and open us up to the more complex human touch components of medical care. Just as a little touch on AI, machine learning solutions as it relates to a lot of the technology that we use, is that a lot of these solutions do allow for the extraction, processing, integration, and analysis of the relevant information that is coming from a lot of the data producing devices and platforms that we utilize. And it provides clinical decision support so providers can provide this high quality care for more patients at once. So there's that scalability, being able to see more patients at a given time because we are augmented by a lot of the information that technology provides. And that will therefore frees us up as nurses and physicians to focus on the more complex decision making, the higher level decision making, and then the human touch aspects of medical care. And then again, you being able to make decisions and having actionable insights from a ton of data, which will inevitably grow larger. And then it allows us to personalize care and to improve population and individual outcomes. I would love to increase incomes as well. But allows us to really personalize care because we, again, have so much data, and we have so much data, and as the technology learns, we're able to say, well, for this particular patient, with this particular medical history, with this living situation, with this, puts them at X risk. And then how do we triage people? How do we get the right services to the right patient at the right time? Those are all really important questions that people who are innovating have to think about. And so important to remember that technology doesn't replace the human touch, but the idea is that it's supposed to enhance and scale it. So I still want to be at the center delivering the care, but I want to be able to use my energy and my time and my attention where I need it and when it is needed, and therefore being able to care for potentially more patients at a given time. And then just more from a philosophical standpoint, so I love home hospital because not only do we get to use this cool tech, not only do I get to meet patients at their home, but you really, really get to understand sort of the disease state and how it evolved when you see a patient in their home. When I go to a patient's home who has heart failure, who can't seem to get it under control, but they say they're taking all their medications, and then I show up at the home and it's like floor to ceiling of canned soup, and they're like, no, it says low sodium, and you're going there and you're walking through the nutrition labels, or their meds are all over the place, and they have like 6 of the same pill, but they think they're different, so they're not taking them correctly. Like, this is very, very common, unfortunately, but we don't get to see that when I'm in the hospital and I'm seeing a patient in a very pristine environment. I control what they eat. I control when they get their meds. I make sure they take their meds. This, in the home, all bets are off, but you really get to see in an authentic way, like, what created this disease state, and why are they here in front of me, and why did they present to the hospital? And then you can really target your energies in the right places where you miss a lot of that. And I practice in the hospital, so I'm speaking from both sides, understanding that you don't get a lot of that view, and meeting the patients at where they're at when you're not in the home. When you've created this laboratory environment effectively for them to get better in, send them home and hope that everything continues the way it was in the hospital. You also engage them when they're inpatient, acute level of care, so that transition. So when I discharge patients and they're already home, I get out of there and I say, good luck. It was a pleasure taking care of you, but they're not going anywhere. Everything that they were doing 10 minutes before you left and discharged them is hopefully going to be a lot more similar to the days that it looks like after the hospitalization, because you've created a habit, you've created patterns and behavior change that has existed within their context, their living situation, their home supports, and so is hopefully more sustainable. And then again, you have this constant communication that you don't necessarily get in the hospital with your patients, where they can reach you really at any given time, and they reach a provider. And so they can reach out to me as the physician. They can also reach out to the nurse for those questions. And then you also increase access. So those who maybe are less engaged with traditional healthcare settings and are maybe more hesitant to go to the hospital, or they're worried about affording the hospital stay, you provide this alternative route for them to get acute care, and they get to do it in the comfort of their home. And if you think about it, during the pandemic, there was a lot of visitor restrictions and all those things that you kind of get around when you're at home, because the patient is living with their home supports. And so that can really help improve their healing as well. So I said a lot of great things about home hospital and why I think it is the hospital of the future. However, the question is, why haven't we adopted it? If I said 30 years ago there was the first model, why isn't home hospital everywhere, and every hospital has a home hospital program? So I think the biggest thing across the board is reimbursement. So yeah, I know, right? It's always the money. It's always the bottom line. And so the inconsistent reimbursement has been the biggest challenge to different health systems being able to deploy a home hospital program successfully. And that is because, at least from my experience when I started, it was prior to the waiver, which I'll speak to very briefly, but we were getting reimbursed at outpatient rates, so like a clinic visit. But we were caring for them all day, and it was an acute level of care. But when CMS had a waiver come out during the pandemic, it allowed us to get reimbursed by Medicare, and in Massachusetts, MassHealth, which is our Medicaid program, for inpatient rates as if they were in the hospital. So when I was billing for my patients when I was on inpatient service, I was billing the exact same at home. And so that reimbursement parity was crucial. And then, so at the beginning of this waiver, 6 hospitals under the waiver. Now there's 204 or more in like 16 to 18 months. Within healthcare, that's fast. Like, change within healthcare takes a lot of time, but I think the silver lining of the pandemic really was that people started looking at telehealth as a more viable option, a potentially more sustainable option, and then you had a lot of these waivers that gave parity to virtual, in-person, home acute care. But that has been a big challenge. But you can see why that was a challenge, because from 1994 until 2020, there was maybe like a handful of programs over like 20, 30 years. And then within like 16 to 18 months, it's blown up hundreds. So just literally making it reimbursed fairly, I would argue, is something that will really propel people or health systems to adopt the model. Obviously, there's concerns about safety. Is it as safe as being in the hospital? Arguably, no, it's not. But if you think about the right patients, yes, it is. And sometimes, I wouldn't say more safe, but I would say more conducive to improvement in their health outcomes, which there's been a lot of studies showing that is the case for home care. And then, of course, there's potential lack of financial or staffing resources to support a home hospital program. Maybe people are just less familiar with it. Requires a lot of education of our ED physicians, of our emergency folks, to say, hey, don't just immediately reflexively send them upstairs. Think about home hospital. Is this a good candidate for home hospital? and to get them on board and to trust that home hospital is a good option and a safe option. And then there may not be enough eligible patients for a certain health system depending on where they're located and what their stretch is. So like how far in geography they can go, because that's a big limiting factor, because you do still want in-person touch. And so depending on how it's set up, for us, we're mostly homegrown, so we insource most of our staffing, so that affects what type of reach we have. But in theory, if you do contracting or have different, like a hub and spoke model, maybe could be in the future something that allows programs to scale or to exist when they may not have the resources right now to have a program. I kind of said to this earlier, I spoke to this earlier, but I think COVID-19, as much headache as it has caused a lot of the world, the silver lining here in this particular instance is with the CMS waiver and other payment parity. So as I said, CMS, generally a lot of the private payers follow, and we've seen that. So even after, I think even the last couple months, we've seen more private payers come and say, we will pay you the same. However, the waiver is not forever. It ends at the end of the public health emergency. There's petition and advocacy being done in the space to try to extend it so that we can get something more permanent. But that plus the hospitals being at overcapacity, so they're like, I need to open up beds. So moving patients was even more critical. Whereas before, if the hospitals weren't full and they didn't have sort of that backfill, then taking patients home just opened up beds and then maybe would sit open. So that component of hospitals being at overcapacity was sort of also part of the perfect storm. And then, openness to telemedicine. We saw it in the ambulatory space first. People are already more open to it. So I think that'll really increase the receptiveness to this new model of hospital at home. So a last word, just, in terms of where we're headed, I think it is somewhat contingent upon a lot of the financials behind it, but it does reduce the cost to the patient. Our patients don't pay anything more than they would pay out of pocket in being in the hospital and being at home. So they pay the same or less. For hospitals and for payers, it reduces the cost. We did a randomized control study at Brigham in 2020 with almost 100 patients, and it showed a 38% cost reduction. And this is just direct cost. So we're not talking about opening up beds and then filling those with potentially higher acuity patients that we could bill more for. Just the direct cost was a significant amount less being in the home than in the hospital. And so there is a big benefit for even the other stakeholders outside of the patient and the provider. And then, it does increase access. It enables earlier intervention for patients at sort of all degrees of sickness. And, I think that as this model has grown, as we've seen, there's been a lot of digital solutions for the telehealth space for the ambulatory setting. But now this has created another bucket of, now we can use digital solutions in the home, but in an acute setting. And then you have the post-acute. So there's just, I think, so much opportunity for innovation in digital health and health tech that will help improve the care. So as tech gets better, I think home hospital will get better as well. And again, the more data we generate, the more data we collect, the smarter the technology gets, and then the more we're going to use it and create this really positive cycle. And then, therefore, allowing a lot of the benefits I spoke to earlier of personalizing care and scaling, the physician and other benefits of a lot of these cool digital solutions. So that's everything I have to say today. I'm open to questions, but appreciate you guys sitting with me through that. So. Any questions? Go ahead.
I have two, actually.
Yes.
So you mentioned that you guys use Epic.
Yes.
And I just want to clarify, are your clinicians in the home using Epic, or are you interfacing data back to Epic?
Yeah, so with Epic, our nurses use Epic Rover. And so that is sort of like the on the fields application. So they're able to enter a lot of the data. It is manual, but it's also the same in the hospital where everything is manually entered by the nurse. But that's how they do it on the field. So it's mostly nursing because they're the ones who are in person all the time.
Right.
So they're the ones entering that data.
Not third-party EMR.
Correct.
Okay, and then my second question is, you mentioned your payers and CMS and as I'm sure you know.
Yep.
Particularly around discharge. I'm not aware that there's any exclusions for these requirements. Did you guys implement like the standard discharge workflows?
Correct.
Yeah.
Everything sits the same. And I think it's a little bit easier to do so because a lot of us are also like Brigham physicians in other capacities, and all the services are mostly insourced, so it's a little bit more streamlined in that way, but it's all the same. Yeah, so the way, even from a workflow standpoint, when I discharge a patient, billing, coding, all the same, in the hospital is the same as in home hospital for CMS.
Mm-hmm.
Yeah, and really for all other providers. I'm not sure what they do on the back end after that, but
Yeah.
yeah.
Thanks, great presentation.
Yeah.
And it's exciting to see changes. You mentioned heart failure, and I was just curious on diagnoses.
Yeah.
Did you focus on a particular group? Did you go after the Medicare hot topics? How did you make that decision, and what specific diagnoses did you look at?
Yeah, so I think the biggest thing is what's feasible to care for given the constraints of our resourcing, meaning, so what types of conditions are okay getting only 2 visits in person a day. So if a patient is on a drip that needs to be titrated from like minute to minute, not a good candidate, right? If a patient is sort of, for some time we weren't doing COVID, so that was an exposure thing. Now we are, but I do anticipate that a lot of diagnoses will increase as the tech improves, as a lot of our staffing improves, and a lot of the resources we have improves. But when we selected initially what types of diagnoses we would take, they were ones that are generally lower acuity. So for example, if you have a heart failure patient who just needs IV Lasix, or which is the water pill, a diuretic, that patient just gets it twice a day. So it kind of fits within those requirements of twice a day visits. We can augment it, like we can do 3, we can do 4 with additional contracted services, which we have access to. But ideally, they're getting those meds twice a day, and they're stable, they're walking around. We look at mobility, so even if your diagnosis is heart failure, but you're not able to get around because you have just so much fluid and the physical therapy recommends rehab, then maybe not a great candidate. So there's like a lot of factors that come together with the diagnosis itself, but based on those criteria, it really is generally lower acuity, they're more clinically stable, don't require as much human touch, usually beyond 2 to 3 times a day. That's kind of how we came up with it. So typically heart failure, asthma, COPD exacerbations, infections that require IV antibiotics. Now COVID will take high blood sugar, so hyperglycemia. Those are some of our most common diagnoses that we see. Yes?
Thank you, Dr. Yang. That was a great presentation. I'm with Blue Cirrus. We're a telehealth consulting company, a national company here, exhibiting and a sponsor of New England Himss. My question to you is, recently I've taken on the role of providing care for my uncle who suffered a stroke.
Yeah.
And he's doing better, but he's been in and out of the emergency room multiple times, and the ambulance rides. The ambulance stops by his apartment monthly. And, do you need a ride to the hospital? He's like, no, I'm fine. But it's getting to be a point like it's too much. He's going in and out too much, and he needs, home care, and he's getting services from elderly services and nursing services. But my question to you is, what are your thoughts on the idea of virtual first? And do you think insurance companies will require a virtual first in the future to try to help eliminate some of this congestion in the emergency rooms and using telehealth?
So there actually are some health systems already looking at this where they have existing infrastructure and programs where they try to prevent a visit to the emergency room in the first place. I do think we'll get there, and that would obviously be ideal. So the patient doesn't even ever have to end up in the emergency room. We do that somewhat here or at the Brigham, where if there's a patient that we have that's in the system and we know them well enough, and maybe a physician who sees them in the outpatient setting says, boy, like I really think, for example, we were talking heart failure, he's like on his way to another exacerbation. We should try to get ahead of it before it does, but his pills aren't cutting it, so he needs IV. Can we just admit him from home? And so we do that for those established patients. It's tricky when we're talking acute because for liability reasons, but also just not knowing a lot of their data, it is important to get that initial evaluation. So the speed at which we can do the evaluation at home currently, given current resources and staffing, is much slower than when they go to the ED. They just basically roll through all the tests, and then within hours have a panel of their labs and their imaging and all of that we can't necessarily do in the home as well, and it's not quite as scalable given our current solutions right now. But I would think that in the future, for the right patient, definitely virtual first, or trying to prevent them from even presenting within the four walls of the hospital, or even ideally or urgent care or clinic, that would be possible. And so if you could think of a world where everybody, healthy or not, has remote monitoring devices, and their device data is going somewhere and being filtered and processed and analyzed, whether it's by digital health solutions or by people, and can be caught early, I think that's where a lot of those solutions could potentially provide benefit and allow for something like catching people before they present, is having that data available, because not everyone even feels that bad, and they come in and they have lab work that's off the charts. So I think in the future, currently it's definitely not the norm, but ideally we can get there. Yes.
What is your average? Oops, sorry. Thanks. What's your average length of stay turned out to be at the hospital?
Yes, good question. So it depends on the diagnosis. So we do have people who are within a day, like their observation levels. So maybe they go to the ED, they have a COPD exacerbation, and they're not feeling well enough to get home. They can't really get to the bathroom without being winded, and they have, maybe multiple stairs to get into the house, those types of things. We might watch them for a day, and then they'll be discharged. But I would say I'd say like 3 to 5 days is probably our average, and that's what most of our studies were showing. I think there was a meta-analysis done that looked at a lot of different data from different programs from home hospital, and it did show the average length of stay was a bit longer than the inpatient average. But if you think about a lot of the diagnoses we take, and also the social complexity of patients at home, the outcomes were still better, but that one parameter of length of stay was a bit longer. But generally 3 to 5 days is where we land. But it can really range. We've had people for weeks getting diuresed, and then we've had people for a day.
Can you talk a little bit about the resources? So is your team just working on patients in this home hospital, or are they part of other jobs also?
Yeah, so I don't know if you guys are all familiar with Mass General and the Brigham, but now we're one, but we have 2 different home hospital programs, and they run totally differently, even though we're within the same system. And so when you say resources, our resources are, we have MDs full-time, we have nurses full-time that are dedicated. When they're on for home hospital. And then at MGH, it's mostly like APP run, and then the physician that's on is like on service. So they're doing something else. So it's just like a different model. I'm not saying one's better or worse. I'm just saying that there's 200 and some programs, if not more, in the United States right now, and there's probably 200 some models. And so there's not a standardized model. I think we need to get there. I think that would, just like inpatient medicine, there's a pretty accepted template for how we deliver care. So I think we'll get there. I think it's still pretty new right now, and people are exploring what's best and best practices. But yeah, mostly for us, we insource our staffing. They're full-time, but other models, even just across the river, a little bit different. So,
Dr. Yang, thank you so much.
yeah.
I'm more interested in really in the vision, sort of the top-down strategy that's being applied to creating this. It's really interesting to look at the outcomes when you start looking at value as energy and money over clinical outcomes. But it may be getting a little too granular, because what I'm seeing sometimes is that there's a push to compare inpatient or hospital-based care with telehealth care, and is that a fair comparison? So, it sounds to me like you were alluding to there being some unique aspects of telehealth that really apply to specific patient subsets. I'm really curious if you could expand on that, and also about the administrative vision of how this is being applied, because I know the bean counters tend to say, let's look at, just inpatient versus telehealth and see where the specific patient subset is, wherever that value graph intersects with outcome. We're going to go after that just for telehealth, and everybody else is inappropriate. Like, what type of vision are you getting from the top down that's associated with some of these epiphanies you're getting?
Yeah, so for your first question about, home-based care being telehealth, I think it's definitely more common now just because it's practiced more. I think the sentiment within the provider space, at least, is that it's not great for everybody. I can't say for the industry piece if they think everybody will eventually be a good candidate. I don't know that that's the case. And so at least within the provider space, no, it's not the same. But I'm guessing within patient, populations that if they're a good candidate for telehealth, that they may opt or prefer it and therefore view their own patient journey of like, oh, when I have home care, it's mostly virtual. What's unique about inpatient home care is that there is still that in-person touch. There has to be, right? Because it's still at an acuity where they require that type of direct care. As far as like administrative top-down, I think unfortunately or fortunately, it does really come down to the numbers, right? Like it comes down to how financially sustainable is this. And while there may not be a direct benefit, for example, like I was saying with the beds, even if there wasn't this waiver, we existed prior to the waiver at Brigham, and while it was not as financially sustainable as it is now, for sure, given the reimbursement models, there was still both an appreciation for innovation and an innovative way to deliver care, but I think a lot of the outcome data was also very convincing to show that like the patient satisfaction increased. There was less consults, so there was less direct cost in that encounter, despite potentially them being reimbursed at a lower rate. And it also opened up beds for potentially higher billing patients. So like that, balance of the scale was ultimately the most important to make sure that there was some net positive, whether it was all in dollars or not, that sort of allowed this home-based acute care to happen. And I think the priorities of most health systems, while they do end up at the bottom line, are still quite different from system to system. And so some are more, I don't want to say forward-thinking or innovative, but they're more known to try new solutions or have the bandwidth to, whereas others may not financially have the means or the resources to support sort of a trial of something new. Does that answer your question?
Yeah, it did. I was sort of triggered by your description of witnessing pill chaos.
Yeah.
That's something like the closer you can get to codifying or structuring data at the level of patient engagement,
Yeah.
the better your outcome is going to be, right? So
Yeah.
like you said, medication non-adherence, why, right? And so like if you can actually say it's because pill chaos or it's because there's nobody there to help them do a pill minder, now you have a path towards improving outcome.
Yeah. As our system is currently structured, I don't think there's a great enough appreciation to be able to bill for that. Do you know what I mean? And so it was a challenge to go from like, now we do some more time-based billing, especially around telehealth. People are reviewing a lot more data. Providers are reviewing a lot more data. But then we're not incentivized to because we don't get paid for that time. So then providers like, I'd rather just see them because then I'm going to get at least paid for the time I'm seeing them, and then I'll review the data when I'm there. So I think there's a lot of challenges that are not aligned. I think the stakeholders currently are not as aligned as they could be to really optimize a lot of these solutions.
I have a question related to how you correlate to I know MGB Home Health.
Yeah.
Do you have a partnership with Home Health to be able to take that person to the next level? So you have somebody come to the emergency room, they're in an episode of congestive
Yeah.
heart failure, they need additional LASIK. You go to their home, you see that there's pill chaos or pantsuit, which is all educational.
Sure.
That you may never change somebody because that's how they've always been. It's
Yeah.
very difficult to change those behaviors. But I see a role for home health follow-up.
Yeah.
Loud enough?
Yeah. Yeah, you elucidate a really important part, which is the transitions of care. That's obviously a high-risk setting for errors to happen, for patients to fall through the cracks. And so for us, with home health aides, we contract our own when they're admitted with us. So if they have their own private, because again, home health aides are generally private pay unless you're getting it elder services, which is covered. But in general, if we see a patient is higher risk, or there's someone who typically has more services at home, we will provide that as a outsourced service. And then if they have their own private pay, we allow them to stay. Again, billing-wise, we can't let their VNA, their visiting nurse, stay. So if we're involved, their visiting nurse cannot come. Sometimes that's their make or break. Usually it's not, but we've had cases where they're really attached to their VNA, and because the VNA can't bill and we can't bill, it's not a good candidate. While everything else is a good candidate, it makes them a good candidate. Literally that one piece of like, I don't want to let my VNA go, who I've known for 30 years, go and have this other random team come in and take care of me in my home. No, thank you. That's just a nuance of some of the billing piece.
Those are some of the barriers to me that should be looked at.
Yeah, exactly, because the continuity is great for that patient who already has a system set up outside, but they're not, active when they're with us. Or like home PT, we use our own PT. So while, if they were home and not admitted, they would have a PT come to their home. When they're with us, they can only do virtual PT because of, again, it's just the billing who's in, like, they have to use our inpatient PT versus maybe their outpatient PT that has been coming to their house. So yeah, it has to all do with billing.
Yeah, hi. This is from Mass General Brigham system, and I work on a system, the transition of care system, the 4NEX system. You may be familiar with the application, and it is for referrals. So it's the case managers who are, sending the patients to their next level of care, whether that be home care or whatever. So when you said the case managers and awareness and things like that, we're about ready to roll out the 2.0 version this fall, and it seems like a perfect, like how do you get this message into the providers in the ED and the case managers in the ED to say this is a candidate for that. So we have all of the facilities and the DME and the home infusion and all of those things are in our system. So I need to talk to you.
Oh, good. We'll connect.
I think we have time for one more.
So one question, going back to that coordination.
Yes.
Having worked at a senior care options plan, senior care options plans in the state coordinate a lot of the care through the elder services functions, which are ASAPs. Are you doing any work with the ASAPs to try to coordinate that so you don't end up with that situation where the person already has the visiting nurse who's been taking care of them and following them, and now you have to sort of break that bond in order to provide the other services?
Yeah. To my knowledge, we are bound to those rules at the moment. I imagine it is very payer specific, but to my knowledge, the payers that we have worked with and I've had any patients with, that has been the case. There has not been an exception where a visiting nurse has been able to continue seeing their patient while we've been there, because they're considered different episodes of care. And if you're considered inpatient, because again, we're billing as an inpatient, then it becomes more complicated for the nursing to get billed for even coming. So then they don't. It just is not. Yeah, even with Mass Health and our patients with Mass Health right now, that is still the case, that we cannot use their nurse. We have to use we have our own, which is the ones that do the 2 times a day visit. That sort of replaces the nursing function of their VNA. But eventually we transition them back. We do referrals, we have case management, and that transition is supported in the same way it is coming out of the hospital. But unfortunately, that is a limitation just given the billing. Well, thank you guys for listening, and feel free to connect with me with any other questions. So, thank you. Oh, thank you. And just leave that up there and probably, I can probably do this.